get to where we're kind of bringing in some leg movement. So let me have you hold like this. Now, if she's in the right position here, she should be loading at her TL junction here. So I need the rib cage down like this. People with that anterior scissors, they're going to be on their sacrum, they're going to be on the thoracic spine. We actually want them at their TL junction. Said a different way, if you see a 5-month-old kid who's developing correctly, you'll literally see the pelvis lifted up off the table. They'll be on their TL junction. You'll see perfect stability. So this is perfect. So she couldn't do this any better right now. So now what we'll work on, let me have you bring your right knee down like literally 2 inches. Perfect. So we should see zero compromise here. Just like with the sprinter, like when Max is going through those drills, you should see the lumbar spine stay exactly like it's going to stay. You'll see the best sprinters, tons of hip flexion, but their spine doesn't move. So we kind of want the same principle here. So go down, press it, come back.
So Brett, if she can't, as soon as you lift the legs up,
right,
and they go into all rectus, do you just drop the feet down and just?
Well, like part of getting better at anything is like struggling with it. So sometimes like we let it kind of suck for a while as they start to figure it out, you know. And another good place to feel this, let me get a little break here, Rachel, is just, you know, because people have to sit all day long, like just starting to learn how it feels. Like to feel like this buttress. And like this is what I do with my kickers. So like I was a really good right-footed soccer player, but I had no left foot. So when you get to a certain level, real quickly, you'll just hear them yell out, oh, he's got no left foot. You're done. I mean, you're just shut down. So anyways, so until now, I'm a way better soccer player at my age now than I was at 21 because now I know the mechanics of kicking so well. So now I have a left foot, not because I got better at kicking the soccer ball, because now I understand what it takes to be a good kicker. So this information is so cool because you can like make them a better player. So anyways, and you'll see like, if we looked at Travis, because he's also a right-footed soccer player, like you'd see on this test, he'll be better at his right foot. On his left foot, because he doesn't stabilize things the exact same way and correctly, you'll see him deviate with his left foot. So this is also a really good time to just like close your eyes and see what it feels like to be here. We do it with cyclists too. So cyclists, hip flexor here, pressure. You'll see like cyclists across the board will hold their stomach in like this. So now they've compromised themselves. Like my female cyclists who they like to cycle with like a sports bra on. So now they're aware of what their stomach looks like. So that I have to address that because they want to be sucked in. Now they're completely compromised. Now they can't stabilize their spine correctly. They destroy their hip and their spine. So okay, so that would be like day one exercise. Now we can get real creative with this if we want. Like we can start incorporating like kind of like a dead bug. So keep all this pressure here, touch, and now uncoil. Good, and now back up. Touch, and now slow it down. Really think about, enjoy the movement. That's a term I like.
What are we doing with somebody with limited hip flexor, like a real jacked up psoas, let's say? Less range of motion?
Like let's say they're tight, let's say. I would argue that they would actually, if they did this right, their hip flexor would be less tight when they got the movements.
Right, but do you limit the range of motion while they're doing it?
Oh, you could. Like she's a freak, honestly. Like,
yeah, no, this is
so like in a good way. So we're here, and then we're just, you know, we just pull it way, 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 way back. Or like a good. What was your question? I don't think I understand your question.
So somebody with limited hip extensibility.
Okay.
Okay. Would you have them go through as much range of motion as she does?
As long as I didn't compromise centration anywhere.
Okay.
Yeah. And then like if there is soft tissue limitation, also part of our home program is a real simple Gary Gray triplanar, you know, mobility here with this built in. That's the other thing.
Right. So the psoas and diaphragm share a fascial connection.
Yeah.
And so once that diaphragm starts working correctly, the fascia can loosen up from the psoas.
Right. Right.
Then you get the digestive.
Yeah, and when you breathe, your kidneys should drop 3 centimeters down. So like proper respiration is across all systems of the body. Again, what I say yesterday, what's the proprioception of organ function called? Interoceptions. One of the ways you know your kidney knows to function well is by having good motility. So like it moving within your body is one of the ways a kidney functions well. Suck your stomach in for me. So now I've completely compromised that. So now the kidneys can't drop down those 3 centimeters. So it affects like everything. It's bizarre. The other thing too, like if the patient's like, Brett, I don't really believe you. You're kind of full of shit. So then suck in your stomach for them. Suck it in. So you'll see how weak they get. Everyone will. Now come back up here. Show me good. Perfect. Now we're strong. So like that's a really good learning lesson for them to kind of see. Or like sometimes just to kind of like work them out a little bit. Go here. I'm gonna create resist. So they're forced to stabilize their spine against the hip flexor. So you can see, you can just get, or you could do like, sometimes we do a ball. They hold a ball like this. They're taught to keep the rib cage down, keep pressure. This is really good for shoulder mobility. Go all, no, go all the way back. So as long as she keeps the rib cage down, this is really good to start to, and what does it also help? Thoracic mobility. Okay. So now we want to activate some of her muscles around her hip. Because
if you had something like post-surgical disc, and like they don't really want to, I mean, they put a lot of limitations. If you did that correctly, you could argue that wouldn't hurt them at all.
You could do it within 3 days of the surgery. Now the problem is you're dealing with people who get compromised. So like, what do your patients do who just had a discogenic surgery? They typically, when you flex their hip joint, they flex their spine. But as long as they can disassociate that, you'd be green light for whatever you want to do.
So just ease into it with like even just stabilizing the legs and putting the hips above.
Yeah, I mean,
Knees above the hips.
again, she's making me look good. Like
Yeah.
your patients aren't like, so it's a struggle. You know, like you'll struggle with them and get frustrated, but that's all part of getting you better. Yeah.
On the disc topic, we were talking about flexion tolerance spine, so you're doing McKinsey aspects, but when we go into a lot of this, we actually have some of that flexion through
Right.
our spine. So just kind of
Okay.
altering perspectives.
Yes, so when I put my McKinsey hat on, I'm solely moving discal material. In my personal opinion, I only use McKinsey for disc arrangement. But I always investigate it just to see. So like, for example, if she came to me with knee pain, I would want to see, does she have in-range joint loss? And if she does, that's going to be part of her home program. Like a lot of patellofemoral cases, you'll see they have loss of terminal knee extension. So part of her home program is terminal knee extension. So, and what the McKinsey people will say is you basically have a derangement in your knee. They're not going to say what it is. It's probably either meniscus, could be, it's debris in your knee, meniscus, cartilage, whatever it is. So how do we move it? The best way to move it conservatively is through in-range movement. So, but then at some point you take that McKinsey hat off, because McKinsey has no understanding of joint centration, and they don't want to understand. They understand that they don't do that, you know. Craig told me an interesting story. He was doing this conference somewhere in Europe, and so Paul Hodges had just spoke, and Rob McKinsey gets up after Paul Hodges, and they had this case or whatever, and so Rob McKinsey just pulls a rabbit out of a hat. Like this case was, you know, chronic, no one helped him. And so he centralizes them within like 2 minutes. The person's, you know, 100% abolished and pain-free. And then, so then someone asked him about the transverse abdominis, and he was at a point in his career, he's like, I don't even know what the transverse abdominis is. That's what Rob McKinsey said. So just to give you an idea, like, we just take the best parts of that system and we use it. And I'll tell you where it shines is in disc joint. And it shines because of the diagnosis value. Not necessarily even the treatment, just like to know that you can help the patient. You know, it's very powerful to know, yeah, you don't have piriformis syndrome, you have a disc derangement. How do I know? Well, 3 sets of 10 brought it up to your spine. So it's very, so yeah. So we use it mostly for that. And you won't see me mix those. Like if you're a McKinsey case to start off with, I mean, I could be doing a bunch of DNS stuff on that same day, but I don't do that. I just roll with what, because you'll be so fatigued as a physician if you're trying to do all this stuff in a visit. I mean, you all know. Like, it's just like, oh my God. So no, and your results will be less, actually. So just educate them on that particular thing. Have them do it really well. Every 2 hours, do 10. Boom, you're off and running. And then they come back, they're centralized. Now we're going this route, you know. Yeah. Does that help?
Yeah, and with that terminal extension with the knee,
Yeah.
and such, like as far as painful patterns, so if they have pain with that terminal extension, I mean, I don't know if you.
I don't. Well, what they say in the McKinsey world is even in the extremities, it will start to centralize. It's a little bit different mechanism than we're dealing with in a vertebral disc, but it will. So like, but you're already supposed to be doing that anyways, because we're supposed to be really good at palpators. So on every patient anyways, I'm already like assessing, okay, does she have in-range knee flexion? Yep, she sure does. How's her hip? Oh, man, she's got amazing hip flexion. Does she have good knee extension? Yes, she does. And I can check a modified Thomas to see like hip extension. So I'm already getting this information because I'm a chiropractor, you know, like, and so whenever I see a stiffness somewhere, I mean, I think you send them home with something to do. Like if somebody says, get lost. If somebody says, I can't tie my shoe like this, a lot of my older patients, I just put them on a program of this. You know, I mean, I'm well aware there's many different reasons why this got tight, but I mean, this is tight, we need to get more motion there. This is a simple way to do it. That's where being able to palpate is so beneficial, because then you can just plug it into whatever mobilization you want. You're good on that? Yep. I need things simple. Like, I don't like to mix a bunch of stuff. And I've learned, like, the clinicians who try to mix a bunch of stuff aren't very good. So, like, stick with what you want to do, and then, you know, roll with that until they're, for example, centralized. Now I'm going to go down my stabilization DNS route. But when you start muddying the waters with everything, it just kind of makes it very, very difficult, I think.
So Mike Pelosi said, when, especially a younger practitioner, which a lot of you are, you take a bunch of shit and throw it together, and what do you get as a result? You get shit soup.
Yeah. And this is the modern day chiropractic student. You're okay at everything and good at nothing. You know, it's like everyone's like Courtney's question a second ago was, what about PRI, DNS? It's like, to me, pick one or the other. You know, because they're kind of getting after the same thing, sort of. So whatever you want, or like Graston or ART, pick one, you know, pick one and then get another tool. Like, to me, those are redundant tools, you know, in a way. Go on your right side for me. Okay, so now, the best way that I know of to activate the glute medius would be through this low oblique sit. Come up on your elbow for me. Okay, so a couple rules that are really important. So some of the main tenets of DNS, as a lot of you know, joint centration, intra-abdominal pressure, period. So before I even start this exercise, I need to be sure this is all right. So here, we need the elbow basically under the shoulder. I need this non-compromised, and if you drew a line like this line should be perfectly straight. So you'll see, like, we need to maybe clean that. There we go. And like, you'll see, like, a lot of people will tell you, like, if they do a McGill side bridge, it hurts their shoulder. Like, it's interesting, fix their shoulder position, and a lot of times they're good. And you can actually, we use this to stabilize the shoulder, you know. Okay, so from here now, when can a baby do this? If you see a baby in this position, you know they're how old? 7.5 months. Yep. So I'm going to use this, and what I tell the patient is this is actually a transition from this position. If you can imagine, you're going from this position to a position on all fours. That's the motion we're trying to capture. The miracle of DNS exercise is all in a transition from one developmental position to another. That's where all the magic happens. So a lot of times I'll give them the cue and say, that's what we're trying to achieve here. And again, I do it. Can I hop on here? So I'm here. So I'm wanting to capture, I'm on my side, now I'm going on all fours. And then the real powerful movement is the eccentric, or the down phase. So as I'm coming down, like this.
What do you think your main cue is on this?
Let's do it. We'll see.
Okay.
Yeah, it depends on the patient.
It seems like people have trouble keeping rib cage to hip. You know?
Yeah, but everyone's got it, or you'll see like hamstring activation, or you'll see this come up. You know, like everybody's got their own little cheat, but it's fun to watch because you get a window of how they want to compensate. Okay, so let's bring you up here. So, like, I bring her up first in this example, and then it's exactly what Max was telling with the running. I need this relationship to be correct. So right now she's a little too intrapelvic tilted. Yes, perfect. We don't need any neck muscles on, so if the SCMs are off, we know we can activate the deep neck flexors from this position. Now we're going to bring this up. And some people will claim to get tired in their hip flexor. If they get the pressure right here, then usually that will decrease the tone on this top leg. Okay. Here we go. So now I just kind of guide. Perfect. And now up. So now I could use any one of these snapshots and